Hi, everyone. My name is Dr. Dani Cuthbert, and I'm a medical oncologist at St. Michael's Hospital in Toronto, where I primarily treat breast cancer. The approach to the treatment of metastatic breast cancer depends on what we call biomarkers on the surface of breast cancer cells. The three main biomarkers are estrogen receptor and progesterone receptor, commonly referred to together as hormone receptors, and the third is a protein called HER2. As such, the specific treatment for an individual patient depends on their subtype of breast cancer, which falls into three categories: hormone receptor positive, HER2 positive, and triple negative. Today, we will focus on the first-line treatments of these diseases. For hormone receptor positive disease, the backbone of first-line treatment is endocrine therapy, typically with an oral tablet called an aromatase inhibitor that is taken daily. However, this may instead be given as a hormone blocking injection, especially if you recently received an aromatase inhibitor as part of your cancer treatment. Endocrine therapy is usually combined with another oral medication called the CDK4/6 inhibitor that works by preventing cancer cells from dividing. These drugs are named palbociclib, ribociclib, and abemaciclib. These therapies can be used in either the first or second line setting, but are given in combination with some form of endocrine therapy. If you have not yet gone through menopause, your doctor will also talk to you about ways to suppress hormones in your body, either with injections to block estrogen production or explore the option of having your ovaries removed surgically. For HER2-positive metastatic breast cancer, patients are treated with a combination of three intravenous drugs called triple therapy. This includes a form of chemotherapy called paclitaxel plus two HER2-directed antibody drugs known as trastuzumab and pertuzumab. The chemotherapy is typically given for up to 8 cycles, and the HER2 antibody drugs are continued so long as they are controlling your disease. As the name implies, triple-negative breast cancers do not express hormone receptors or HER2 positivity. This disease subtype unfortunately has the worst outcomes amongst patients. The first-line treatment for triple-negative breast cancer includes intravenous chemotherapies with common options including paclitaxel and carboplatin. Your oncologist may also offer you immunotherapy based on a specific feature of your pathology called CPS, with a higher score, meaning that your cancer is more likely to respond to immunotherapy. Immunotherapy is an intravenous treatment given every 3 weeks, which activates our body's own immune system to fight cancer. However, our normal tissues can be affected by immunotherapy, and side effects include autoimmune conditions and inflammation of various organs, of which rash and thyroid issues are most common. However, more rare but serious toxicities can affect the lungs, colon, heart, and other organs. And briefly, if the cancer has spread to the brain, then radiation is usually considered to treat these areas. Ultimately, you should engage in shared decision-making with your oncologist when discussing therapies. It's important for your oncologist to know your history, your medications, and preferences when recommending a treatment plan for you. Side effects should be reviewed, and you should also have the opportunity to ask questions before starting any treatment. In some cases, your doctor may discuss clinical trials with you too, which are typically studies being done to assess the efficacy of newer therapies that may not otherwise be available to you as standard of care. Lastly, it's important to note that this was a broad overview of first-line therapies. However, there are multiple lines of therapy available for each disease subtype, and your doctor will guide you through this treatment journey. The general approach is to continue a specific therapy so long as it's providing control of your disease, which is assessed by a combination of imaging scans, blood work, and seeing how you are doing clinically. Overall, there have been many recent advancements in the treatment of metastatic breast cancer, with more promising novel therapies on the horizon.